I'm Dr. Athira Goudaman, junior resident from Trivandrum. Small patients and big challenges. I'm talking about MOGAD. I'm talking about a patient who came with a child who came with chief complaints of sudden onset pain in the right eye, followed by defective vision of 1 week duration, associated with history of pain on eye movements. History of fever 2 weeks before the onset of eye symptoms. No history of recent immunization, no history of weakness, numbness, or headache, nausea, vomiting, and no history of seizures. On examination, in the right eye, visual acuity was 6 by 16, not improving with pinhole, and pupils grade to RAPD, color vision, red desaturation, and light brightness sensitivity was all abnormal, and the left eye was normal. Fundus, right eye, showed hyperemic edematic disc with blurred margins and peripapillary edema up to half this diameter area around the disc. And this is a right eye fundus picture, and left eye was normal. Neurology evaluation was done, and MRI brain and orbit contrast was taken, showing mild thickening of the intraorbital segment of the right optic nerve. Flash VP showed reduced P wave amplitude and delayed onset of P wave. Antibody profile showed anti-MOC IgG antibodies strongly positive, anti-aquaporin 4 IgG antibodies was negative, and ANA profile was also negative. She was started on injection methylprednisolone 30 mg per kg per day for 3 days, followed by oral Vizelon, and the patient was reviewed after 5 days. She was symptomatically better with visual acuity of 6 by 6 in the right eye. After 8 months, the child again presented with defective vision and pain in the left eye since 1 day duration. On examination, right eye was found to be normal, and the left eye visual acuity was 6 by 24, not improving with pinhole, and grade 3 RAPD. Color vision defective, red desaturation was positive, and light brightness sensitivity was decreased. And fundus, right eye appeared normal, and left eye was the fundus was hyperemic edematous disc with blurred margins and peripapillary edema up to half disc diameter area around the disc. And this is a right eye fundus picture. This is the left eye. OCT optic nerve head showed left eye peripapillary RNFL thickening increased in the inferonasal, temporal, and inferior quadrants. MRI brain and orbit contrast was taken, showing thickening of the intraorbital segment of the left optic nerve. And the diagnosis of MOGAD associated optic neuritis was made. Discussion. Myelin oligodendrocyte glycoprotein antibody associated disease is an inflammatory disorder of the CNS characterized by immune mediated demyelination targeting the optic nerves, brain, and spinal cord. And it is common less than 18 years of age, and the male is to female ratio is 1:1. Incidence of MOGAD is higher in children than in adults. Incidence is 3.1 per 1 million. And in pediatric populations, it accounts for nearly 50% of acute demyelinating syndromes. Acute disseminated encephalomyelitis, or the ADEM, is the most common of all presenting cases of pediatric MOGAD, and optic neuritis is the second most common manifestation after ADEM. The annual incidence of MOGAD related optic neuritis is approximately 1.6 to 4.8 per million people. Optic neuritis is mostly bilateral, but simultaneous bilateral optic neuritis occurs in 31 to 84% of all MOGAD cases, and approximately 67% of the IgG positive patients experience more than one optic neuritis attack during the follow-up. And disease courses in children is milder compared to adults, and it is more likely to experience complete recovery, and challenges can be early diagnosis and treatment and variable presentation leading to misdiagnosis. Predicting the course of disease and managing long-term complications can be challenging for the physician. Thank you.
So clinically, if you have to differentiate MOGAD from optic neuritis in, let's say, a child or an adult, what would be the clinical features that you would look for specifically, or even the radiological features?
So we can see in the, in the MRI we can see, sir, the long segment will be involved. Mostly in multiple sclerosis, short segments along with the long segments will be involved. In case of aquaporin 4, only the long segments will be fully involved.
Yes, and any other places in the brain or any other things that get involved?
So the periventricular areas will be involved, sir.
In what?
In case of
so how is the periventricular involvement of MS different from what you would get in MOG or MOGAD disease? So those typically described dorsums, fingers, and periventricular, juxtaventricular would be there in the MS, but they tend to be a little more spaced out and further away in the MOGAD disease. As also involvement of the chiasma is more common in MOG. You tend to get that involvement as well. So these are some features, and clinically, of course, behaves slightly differently and it has a higher chance of recurrence, and the outcomes are poorer compared to what typical optic neuritis would have.
And even the presentation, how the patient present with how much vision loss.
Yes, ma'am.
That is also differentiating. So you do these tests in all the patients of neuritis comes to you, or is there any indication of doing which test in which patient?
Ma'am, in pediatric patients, mostly it is MOGAD is one of the differentials because it is very unlikely to be multiple sclerosis or
So you do it in all the pediatric patients?
Mostly we, along with MRI, we opt for a MOG antibody and ANA profile. Along with that, we sent all these together. So that is one of the.
So pediatric optic neuritis, if you look at the as a whole, then you've got seronegative and seropositive. Within seropositive, MOG is more commoner than NMO, right? Almost about 29% would be MOG as against about 7% NMO. And then there's ADAM, which is basically the bigger group, which again comes into seronegative, but would present very much sometimes like optic neuritis to begin with. So it's it's something that we're getting more frequently now that we are testing. But as Dr. Anita was pointing out, you don't need to do all tests and all. It's only indicated where you're specifically finding one kind of a clinical presentation or a radiological presentation.